in the context of COVID-19. A few housekeeping tips. Please keep your video and audio off. Introduce yourselves in the chat box. The webinar will be recorded. It's being recorded now. And the webinar and slides will be available on the website afterwards. My name is Brooke Bauer. I'm with the Tech RT. I'm the IYCFE advisor. We'll be introducing the presenters in just a minute, who will be giving the rest of the presentations today. We know that pregnancy and breastfeeding are times of nutritional vulnerability, where nutrient needs are increased to meet physiological requirements to sustain fetal growth and development and protect the health of mothers. We know globally that many women are unable to meet those needs. It has negative consequences not only for their health, but also for the health of their infants. And then we know that in the context of COVID-19, women and girls are likely to face additional risks that impact their diets, their nutrition practices, and their access to services. So today we have presenters from WFP and from UNICEF who have collaborated to develop the content of the webinar and who are also presenting. And we want to thank those presenters because we know that they're in the field, they're frontline, and we want to thank them for their time to develop what they've done today and also take the time to present it. We want to thank you all for joining us. And we look forward to having a good webinar today. Tech RT is supported by USAID and OFTA. We are with GTAM. The GTAM is a common global mechanism endorsed by over 40 global nutrition cluster partners to provide systemic, predictable, timely, and coordinated nutrition technical assistance in order to meet the nutritional rights and needs of people affected by emergencies. We will be putting, if you require any support, we'll be talking about that in a little bit. If you require any support, we'll be putting that link in the chat box on how you can request that support through the GTAM. We have presenters today from WFP and UNICEF, and our question and answers will be with Colleen from World Vision. The webinar, the objectives today are to provide an understanding of maternal nutrition and program adaptations within the context of COVID-19. We want to present, as I said, the brief, Protecting Maternal Diets and Nutrition Services and Practices, and we want to present country-level experiences on maternal nutrition programming in the COVID-19 context. And we want to give opportunity for you all, the practitioners and the ones at the front line, to ask questions on the brief. And we want to be able to work to answer some of your questions that you might have. So today for our agenda, we'll go through our objectives and introductions. We'll introduce the presenters. Our first presentation will be with Deborah on maternal nutrition and vulnerabilities in the COVID-19 context. Next, we'll be discussing protecting maternal diet services and practices in the context of COVID-19. We'll look at 3 case studies, one in Somalia, India, and Pakistan. We'll give you information on how you can request technical support. We'll have a question and answer session, and then we'll ask you to do a webinar evaluation. Throughout the webinar, please don't hesitate to put your questions in the chat box. We'll be collecting them and working to answer them at the end of near the end of the webinar. As I said, my name is Brooke Bauer. I'm the Tech RT IYCFE advisor. We'll have the rest of the presenters introduce themselves. Dr. Yassir, unfortunately, who developed the presentation and was going to be presenting, is unable to be with us at the moment, but with us instead is Dr. Ayad, who will introduce himself in that place. So Deborah, if you're able to introduce yourself, please.
Hello, hi, I'm Deborah Joy Wilson, Maternal Infant and Young Child Nutrition Specialist, the World Food Programme based at headquarters.
Hi, I'm Ani. I work at the UNICEF India Country Office.
Good morning, good afternoon, and good evening. My name is Neetha Dalmia. I'm the Maternal Nutrition Specialist for UNICEF, based in headquarters, New York.
Dr. Ayaz?
Hello, my name is Jacinta Chen, Nutrition Manager for UNICEF based in Somalia.
Kiara? Kiara or Pramila? And we also have Daisy and Colleen. If either of them want to introduce themselves, that'd be great.
Hello, everyone.
Hi, this is Kira, Nutrition Officer.
Hi, everyone. My name's Colleen Emery. I'm a Senior Technical Advisor with World Vision International. Nice to be here today.
And hello, everyone. I'm Daisy Nyaga. I'm a nutrition consultant working at the World Food Programme, Somalia Country Office. Thank you.
Great. Thank you very much, everybody. And before we start, we want to learn a little bit from those of you who are participating in the webinar. So we have a small poll that will be put up. And we'd like to know, is your organization currently or planning to support maternal nutrition programming in the context of COVID-19? You can either answer currently, planning, not planning, no, but advocating. This is an informal poll. It's anonymous. It has, even if you're not entirely sure of the answer, it's just an indicator of who you have on the call. So please feel free to answer that. And we'll give it just a couple minutes for that. Great, thank you very much. So our first presentation will be with Deborah Wilson with WFP. She'll be talking about understanding maternal nutrition in the context of COVID-19. And we're really thankful to have her here. So Deborah, if you don't mind taking it away.
Hi everyone. So I'm very quickly going to go over an understanding of maternal nutrition and then highlight some of the vulnerabilities within the COVID-19 context. Next slide, please. So maternal nutrition requirements, both, first of all, when we refer to maternal nutrition, we're relating to a mother. So in this context, we're considering pregnancy and the duration of the breastfeeding period that's recommended. So most of you will have heard about the importance of the first 1,000 days of life, which is from conception till a child is aged 2 years of age. And this is a critical opportunity to lay a foundation for the child's nutrition, growth and survival. and that has benefits throughout the lifetime. But also importantly, within this period, it's important for the mother's own nutritional needs, that they're protected and supported for both her own immediate and longer term health and her caring capacity, as well as the health and development of her developing fetus and her infant. So the increased needs for physiological and metabolic requirements, sustain fetal growth and development, protect the health of mother while breastfeeding and pregnant. So during pregnancy, there's need for increased nutritional intake for maternal fetal metabolism, amniotic fluid, and adaptations to the maternal tissues as well. Now, during the lactation periods, the mother needs more nutrients for the breast milk production, for promoting recovery from childbirth, sustain the mother's health, as well as has increased physical activity, typically more than during pregnancy. So yeah, there's increased requirements both in pregnancy and lactation for more energy than in the pre-pregnancy state, and also for several micronutrients. And the additional needs continue until the child starts gradually taking less breast milk. So considering this, there needs to be appropriate weight and weight gain during pregnancy, because and that will be individualized based on a mother's BMI during conception, the woman's age, activity level, and both low and high weight and weight gains can result in adverse pregnancy outcomes for both the mother and the child. So we often assess the nutritional intake using the minimum dietary diversity for women indicators. So globally, many women do not meet their dietary needs, and especially during pregnancy and lactation. So this has negative consequences. Next slide, please. So within the context of COVID-19, we've got recommendations going out about public health, messages about food safety, social measures that are being promoted, as well as service provision modalities which are being modified. So women and girls within any emergency context experience distinct challenges and risks, and this is also applicable to the COVID-19 outbreak. And they can exacerbate already existing inequalities, and this has repercussions on poor maternal health and the health of the fetus and the child. And these vulnerabilities exist at individual level, population level, as well as the way we programmatic service provision levels. Next slide, please. So these are just some of the vulnerabilities that may exist in some contexts, and it's not exclusive, and also they don't apply in all contexts. But there are women who are pregnant and lactating have specific physiological requirements. They have changes in their hormone levels. Their immune system function is compromised during pregnancy in particular. And then you've got risk factors for a young age at the first pregnancy, multiple pregnancies, and also close birth spacing, which for a young age at first pregnancy, when a girl is still growing, she's still needing to provide for her own body as well as the pregnancy. Multiple pregnancies and close birth spacing challenge the health of the mother. So, and the nutrient requirements. There are also lots of beliefs, cultural, social beliefs about pregnancy and lactation, and these certainly also arising within the COVID-19 context. Socio-cultural factors and gender norms. Women in many countries that we work in, they have low visibility, sometimes not included in assessments. They have sometimes low decision-making power, low education level illiteracy, and yet they have a key role in caregiving at household level, and with an increase in potentially people housebound. Sometimes this can challenge her. Also, as it's been, in emergencies and with the COVID-19 context, as the increased risk of maternal health issues, especially psychosocial issues. So communication, there's a lot of false beliefs and misinformation. So we need to consider this and a lot around that would relate to the practices during pregnancy and lactation. There's sometimes a lack of access to information, and that can be related around lack of mobility or low education level and literacy. And the use of digital platforms that's so highly promoted, sometimes women do not have access to these digital platforms. So really need to think of how we can reach women, especially pregnant and lactating women. Disruptions in food systems, perhaps the markets aren't functioning as, or the access to actually go to the markets, the lack of transport, the markets not operating as frequently, food prices increased, household food allocation in many contexts will favour other members of the family and not the women. And there might be increased reliance on cheap staples, and increased risk of malnutrition, and coupled with that, the cross-border or even within a country movement of food supply chain can be limited within this context. Next slide, please. So first of all, I'll go over the essential nutrition support services. In so many countries, the health systems are already weak. Mobility restrictions or fear to go to a health facility for ANC, for PNC visits, fear of getting transmission, of the virus, limited transportation, the capacity of the health systems with resources perhaps directed through to COVID-19 and other priorities, and supply chain breaks of, for example, micronutrients and other support that a woman requires, the inability for weight monitoring, etc. And also women rely very much on community support structures, that social support network of learning from other people, and if you have distancing, this may not be available. Could you move the slide down a little bit? Yeah. Hygiene, women during pregnancy and lactation, as in other situations, but they need to consider what, hygiene and prevention of infection with the increased risk of general infection, such as diarrhea. So what's the availability of clean flowing water, soap and other personal hygiene items, considering that this can be competed with supplies going to other people with the COVID-19 response? And next slide, please. So that's just a very, very quick run of some of the things that need to be considered when programming for maternal nutrition in the COVID-19 context. Many thanks.
Great, thank you very much, Deborah. We'll go to the next slide now, or the next presentation now.
Good morning, colleagues. Thank you for joining this webinar. Today I'll present on the guidance for action for protecting maternal diets, services and practices in the context of COVID-19. Next slide, please. So in this presentation, I will cover the impact of COVID-19 on maternal nutrition services, followed by an overview of the objectives of the global guidance, which has been developed jointly with partners, and then finally move on to some of the key considerations in planning and implementing maternal nutrition programming, along with some recommendations for actions. Next slide, please. So COVID-19 is impacting the delivery of maternal nutrition services worldwide. Here I show some preliminary data gathered by UNICEF, which shows the impact of COVID-19 on maternal nutrition services and other nutrition services. We can see that some of the reasons cited for the coverage drops include lockdowns, which are restricting women from using services and accessing transportation, reduction in demand due to fears of infection, and we've also heard anecdotes from the field about this, the closure of services and postponement of services, the suspension of community engagement, which is something that we've heard in other global epidemics too, personnel gaps from health workers, community workers getting sick and facing the same sort of mobility restrictions as women, and fear, of course, of turning up for work. And then the unavailability and stockouts of key supplies at service delivery points. Next slide, please. So some of the objectives for the guidance on action for maternal nutrition include providing decision makers and implementers with some recommendations to protect the diets, services, and practices of pregnant women and breastfeeding mothers. The guidance focuses on the mitigation phase for countries experiencing partial or full mobility restrictions, with the idea that services would be adjusted in line with national recommendations. It recognizes the need to periodically update as new information and evidence emerges, and this is why the guidance has been mentioned as interim. And then finally, the guidance has been translated into several languages, including Arabic, French, and Spanish, to facilitate the global rollout. Next slide, please. So just a point on the fact that these global actions that are recommended in this guidance are aligned with global evidence base and other broader guidance on COVID-19. For instance, we've taken into consideration the WHO guidance on maintaining essential nutrition services in the COVID context, UNICEF's guidance on COVID-19 program priorities, including recent guidance that's been issued on financial and in-kind contributions from food and beverage companies in the emergency response. A statement issued by the Task Force on Multiple Micronutrient Supplementation Use in the context of COVID-19, and then the joint statement issued by WHO, WFP, and UNICEF on preventing and controlling micronutrient deficiencies in populations affected by an emergency. Next slide, please. There are some key considerations when planning and implementing maternal nutrition programming during COVID-19. The first is around strengthening the governance for maternal nutrition programming. Oftentimes we see in emergencies that there's not enough emphasis given to maternal nutrition programming, and here some key considerations are provided to ensure that financing, coordination is in place for maternal nutrition programming, and that key maternal nutrition indicators are included in the assessments and in the routine monitoring during the pandemic. The second key consideration is ensuring the context-specific specificity of the program design to make sure that this is aligned with global evidence base, the local data that's available, the local context, and is in line with national policies and strategies. The third consideration is around the fact that multiple systems are going to be needed, going to be activated to ensure a comprehensive response to ensuring maternal nutrition is protected during the COVID response. And this includes food systems, health systems, and social protection systems. And later on in this presentation, we'll hear from India, Pakistan, and Somalia on how they are using these various systems to provide a maternal nutrition response during this pandemic. Ensuring that the response includes gender responsive programs, that is, the social protection systems are designed and implemented to ensure women's interests, to ensure that there's community participation. We've learned some important lessons from the Ebola pandemic, where the role of communities was very important in terms of making sure they were mobilized to return to services, that they received the right kind of information, particularly since there was a lot of fear in terms of returning to services. And then finally, the fact that emergencies present an opportunity to accelerate policy changes, to introduce new interventions, and to simplify and innovate in program approaches. Next slide, please. So the recommended maternal nutrition actions are organized around 6 main areas. The first one relates to the prioritization and maintaining the continuity of maternal nutrition services in the context of antenatal care. So the guidance provides some recommendations on how certain service adaptations may be made, which would include e-learning, redeployment of staff to COVID hotspots, task shifting, the use of telemedicine and SMS, and also the fact that there's a core package of maternal nutrition interventions that should be included as part of maternal nutrition services during the COVID response, and this includes breastfeeding and nutrition counseling, the use of micronutrient supplements, weight gain monitoring, just to mention a few. Then ensuring that there's an uninterrupted supply of essential maternal nutrition commodities. The guidance recommends pre-positioning 3 months of supplies and also ensuring that there's additional amounts of supplements that are dispensed to pregnant women when they come for services. The third area of work is everything relating to general recommendations on ensuring food systems protect the diets of pregnant women and breastfeeding mothers. So there's some recommendations given to ensuring that local markets continue to supply nutritious foods, including fruits and vegetables, animal source foods, and dairy products, ensuring the continued provision of fortified foods, ensuring that local markets remain open during this time and that they practice social distancing and food hygiene during this period. And then finally, and more importantly, is making sure that that we're protecting the commercial interests, protecting pregnant women and breastfeeding mothers from commercial interests and from unnecessary exploitation, pushing of unhealthy foods and breast milk substitutes, along with the unnecessary use of supplementary foods and their spillover. The fourth area of work relates to expanding social protection programs to ensure that they include in-kind food, vouchers, and cash, ensuring that food distribution is closer to communities to facilitate women's access, and to ensure that food safety nets include nutritious foods, including lentils and fresh fruits and vegetables. The fifth area of work relates to communication strategies on healthy eating and food hygiene. And here this will require using innovative approaches to ensure that women and children receive messages on healthy eating and food hygiene, that health workers have access to e-learning tools to be able to do this. And then the fifth area of work includes everything related to nutrition information systems and assessments, ensuring that maternal nutrition indicators are included in the routine monitoring systems, and making sure that gender markers included in nutrition assessments and then the use of innovative methods such as SMS and other e-tools to make sure that we can actually collect this data. And with this, I'd like to thank you for your attention and pass it back to Brooke. Thank you.
Brooke, you're on mute.
Apologies. I just want to note thank you, Nita. I just want to note very quickly before we go to the case studies that we have nearly 500 participants in the webinar at the moment from all around the world. Particularly, we have a lot of colleagues from South Africa, Indonesia, Nepal, and India. So welcome everyone. And now we'll go to the maternal nutrition in a fragile context for Somalia. Thank you.
Thank you, colleague, and it's an opportunity to share what is happening in Somalia. Basically, in Somalia, we know that the context of Somalia is a fragile country where the implementation might not be the same as in other countries. So maternal nutrition requires more of a multi-sectoral approach, as indicated both by Deborah as well as Nita. So in terms of the service implementation, we really need to bring in different partners. In a fragile context, we have different challenges, including aspects to do with different partners implementing in a fragmented way. We have a weak health system that is in place that we have to deal with. And also there are sometimes issues with data to monitor the maternal nutritional trends. We have, in this current context of COVID-19, the challenge with also frontline workers actually having infection from COVID-19. Next slide. So when looking at the outline of our presentation, we'll be looking at maternal nutrition program elements, both covered by UNICEF and WFP. And we are also looking at some of the modifications, the constraint that we are facing, what are some of the evidence and the way forward that we want to move with it. So next. The current program that we want to share with you is a resilient program supported by KFW. So it's looking at both working jointly with UNICEF and WFP in about 15 districts in Banaadir and Gedo districts of Somalia. These programs included, for UNICEF, will cover how we have implemented the micronutrient supplementation, while WFP will look at the different programs they have covered, and then we'll go straight to look at what are some of the joint elements of the program that we are working on together with UNICEF and WFP. Next. Next. So in terms of the micronutrient supplementation program, we actually looked at as Somalia country office, we looked at the joint statement given by UNICEF, WFP, and WHO on micronutrient supplementation in the context of COVID-19. But also we also referred to the WHO ANC guideline that would help in the implementation of micronutrient supplementation in a more prevalence, countries with prevalence of nutrition deficiency. So micronutrient nutrition supplementation is considered as a basic package of the nutrition package in Somalia. And basically partners do distribute micronutrient supplementation during their implementation. And there is a very strong link with the community. The community health workers help to deliver messages to the households. And in this context of COVID-19, during the program modification, and we had a virtual training of all the implementing partners in Somalia, they are implementing one-on-one counseling of the mothers so that they know what they need to do and how to take the supplement. The micronutrient information is actually well captured in the national HMIS or DHIS2. So this is clearly being documented and well captured. And actually in 2019, we, in the 15 districts that I mentioned, we achieved over 48% of the PLW were reached. Out of the planned 92,000, we were able to reach over 137,832. So, I mean, if we really put emphasis in terms of really making sure that the messages are out there, improving the diet, and we know very well in Somalia, given the repeated emergency and also the climate impact, sometimes they do not have access to fresh foods. But this micronutrient supplementation helps the mothers to improve their diet. Next. And I'll be giving it to my colleague to present from WFP. Over.
Thank you, Jacinta. In terms of WFP-led activities, WFP's support to maternal nutrition can be broadly categorized into prevention and treatment. Under prevention, mother and child health nutrition, under MCHN, pregnant and lactating women receive monthly support of specialized nutritious food, linking with integrated health services, antenatal and postnatal care, IYCF, deworming, alongside social behavior change communication on health, nutrition, and diet diversity. In addition, pregnant and lactating women also receive electronic transfer to improve access to fresh fruits and vegetables and improve their diet diversity. A PDM post-distribution monitoring conducted in November 2019 showed MDDW of 68%. That is, 68% of benefiting women consumed 5 or more food groups out of 10. As a part of a continuum of care, mothers delivering at facilities also get MCHN delivery incentives, promoting facility-based delivery. And that is the preventive part. Under the treatment part, WFP is treating malnourished mothers in TSF centers with specialized nutritious food. Cure rate is encouraging at 94%. Next slide, please. So, under the COVID-19 modifications, let me first talk about how we adapt the modifications. When we received the global guidance from the headquarters and Global Nutrition Cluster in Somalia, first we had consultation among WFP, UNICEF, and Nutrition Cluster, context the guidance to Somalia, the Somalia context, and then modification in programming were adopted. In terms of health facilities, regular mass communication was discontinued, but switched into the one-to-one counseling at the health facility level. Fortunately, all the health facilities are still open, and antenatal care, postnatal care, and the other essential health services are still continued. The community health workers were then trained, mobilized to provide household level outdoor visit, and then follow-ups are done through use of phone. Similarly, active screening of pregnant and lactating women continues with low or no touch principle and has been shifted to household level. Respecting the guidance of social distancing and reducing crowd, MAM treatment and MCHN distribution cycles were modified from once a month to once every 2 months with increased rations, pre-positioning the ration. Any distribution and the distribution dates have been staggered. The last point here on the food assistance to hospitalized COVID-19 cases is still under discussion with the government, not yet implemented. Over to you, Daisy, for challenges.
All right, thank you, Pramila. So according to the cost of debt analysis conducted in Somalia in 2019, we saw that it costs a household $8 to be able to achieve a nutritious diet, and yet the average earning is $1 per day. In this context of COVID, it becomes difficult. Please go to the next slide. in this context of COVID, it becomes difficult to meet the nutritional requirements of women and lactating mothers. Also, the coverage of iron supplementation is low. We see from the DHS survey that was done in 2020 that we have 12% of women having used iron supplements in pregnancy. However, UNICEF is the sole provider of the micronutrient tablets, while WFP is providing SNFs. Therefore, we see that we have a challenge in funding to provide these micronutrients to women despite the low coverage. Also, the other challenge we have is that it becomes difficult for mothers to monitor their own nutritional status, despite the fact of us having shifted to mother-led work, because we trained partners through the nutrition cluster. However, due to the challenge of wanting to observe social distancing, the trainings rolling out to communities and to mothers still has not been covered 100%. Therefore, we are seeing a challenge in mothers being able to monitor their own work without training. And then finally, our monitoring system is lacking a growth monitoring indicator and mechanism for tracking the use of micronutrient. Over to you, Kiara.
Great,
thank you.
Daisy. So in Somalia, we now know a lot more about maternal nutrition than ever before, which really is a great achievement for such a fragile context. So in 2020, we have the DHS, the first micronutrient survey in a decade, the fill the nutrient gap analysis that Daisy referred to, and qualitative maternal nutrition research in the program areas of this resilience program. And so you can go to the next slide, please. The results of the research really highlight the interconnectedness of issues, especially for somewhere like Somalia with such a weak health system. And this means that women can actually be reluctant to engage with services in the first place, and then they lack trust in services. And in addition to lacking trust in services, some women aren't even aware of the services that are available to them. And then when it comes to social norms, they're entrenched in Somalia. So according to the DHS, 99% of women have FGM, more than a third are married as children, so before they're 18, and almost 40% of women have had a child by the time they're 19. And so then it follows that these young women prefer smaller babies because they're perceived as safer. And all of these factors make it very difficult to tackle maternal nutrition in a short time frame. And then when it comes to micronutrient supplement, our qualitative research has shown that women lack information on the importance of these supplements, and sometimes supplements aren't available in the health facility. And then finally, to add, it's the adolescent girls that suffer the most in all of this. In our focus group discussions, they reported missing meals, and they're consistently the most vulnerable in terms of their pregnancy outcomes, like Deborah referred to. And so next slide, please. All of this evidence is a massive step in paving the way forward, and it's going to inform our programming for the next decade. So we're now working closely with health colleagues to develop social and behavior change activities that are going to target maternal nutrition specifically. And then in particular, we're really focusing in on first pregnancies, because this innovation helps us to reach adolescent girls without discriminating on the basis of age. And so our first pregnancy focus also doesn't rely on reaching girls through schools, because in Somalia, so many girls are out of school. And this way we can better get at issues like difficult labor, avoiding weight gain and bigger babies. Again, all of those issues that Deborah mentioned at the start. And we can help women to become more familiar with the services that are available to them. Then, of course, there are the issues that are familiar to all of us, like securing funding, working across sectors, and evaluating how well we're meeting women's needs. So with that, thank you very much. And we look forward to your comments and questions in the Q&A. We see lots of them coming through already. Thank you.
Thank you, Kiara. And we'll go straight into our next case study with India.
Greetings to all those participating. And I'm presenting on behalf of the 11 collaborating institutions whose logos you see on the slide. These include academic partners, All India Institute of Medical Sciences, Lady Irwin College and Institute of Economic Growth. Each of these institutions are serving as technical support units to the Government of India for anemia, maternal nutrition and healthy diets. Also represented here are Alive and Thrive, IFPRI, Nutrition International, Bill and Melinda Gates Foundation, our sister UN agencies, UNDP, World Food Programme, WHO, World Bank, and UNICEF. I'm here to share our collective story with you. Our story of how we are supporting national and state governments across 17 Indian states that comprise 90% of India's population to protect maternal nutrition diets, practices, and services in times of COVID using a health sector and systems-led approach. Why health sector and why systems approach, you will see in the next slide. Next slide, please. Health sector approach because health sector is driving the COVID response in the country, and systems approach because maternal nutrition is a part of the essential service of the government-funded, government-led antenatal care program, which is delivered in India through a systems approach. If you look, let me give you a little scale and the services of maternal nutrition. There are 30 million pregnancies in the country. Each of these pregnant women are entitled to a package of essential nutrition services of the antenatal care program. The services are listed here. As you can see, balanced energy protein supplementation, micronutrient supplementation.
Apologies, everybody. I think we have a bit of a connection issue. We'll go ahead and work to fix that as soon as we can. I think if we want, can we, Rita, are we able to go to the last presentation to see then if we can get Bonnie back on? Can we go to the next case study for the sake of time while we get Bonnie back on? Great, thank you very much. Great, so we'll speak with our colleagues from Pakistan. We'll go ahead and with their presentation, and then we'll work to get our colleagues from India back on.
Okay, thank you so much, Brooke, and let me take this opportunity to thank everyone for letting Pakistan present its case study. So title is Maternal Nutrition and What Adaptive Measures Are in Place in the COVID-19 Context. Next, please. Okay, so I would wish to present the situation analysis about Pakistan. Like, if you look at the situation in Pakistan, the preceding 4 or 5 decades represent a continuing of malnutrition emergency in the country. The stunting rates have always remained above 40% as of 1965. So if we look at the current critical role of maternal and child health, we all know that improving maternal outcomes, pregnancy outcomes, can prevent against acute and chronic malnutrition. Pakistan has prioritized maternal malnutrition initiative due to a critical impact on stunting. So actually stunting was the main challenge which highlighted and sensitized the policymakers to focus more on the maternal nutrition. The most recent National Nutrition Survey, 2018, indicates the worrying situation of the same challenge of malnutrition. For example, the macro and micronutrient deficiencies in the women of reproductive age indicates like 14.4% of underweight, 24% of overweight, and 13.8% of obesity as well. So we are facing the double burden, undernutrition at one end and overnutrition at the other hand in the women of reproductive age. There has been a high prevalence of micronutrients like in the form of anemia with almost 48%. Similarly, vitamin A is another challenge with 22.4% prevalence. So high rates of undernutrition and micronutrient deficiencies in these women of reproductive age has contributed to the vicious cycle of malnutrition which is continuing in Pakistan. Next data, please. Okay, now before I proceed with the COVID-19 specific details, the slide presents an overview of what I presented in terms of under and over nutrition of how it affects different provinces. So a provincial breakdown is presented. I will not go into each and every detail, but if you look at the women of reproductive age by province, almost every province of the country is facing the challenge of malnutrition. If we look at one of the very unique study in this context, I'll go back to 2016 when the government identified the need to analyze the data and through Planning Commission of Pakistan, and WFP came up with the technical support to present the study of fill the nutrient gap using the cost of diet analysis tools. Similar findings presented later on contributed to incorporation of mega studies in the form of social protections like Benazir income support program. So why the need came for this fill the nutrient gap was mainly driven by government, and we all know that if we talk about malnutrition, there are mainly two prerequisites, either about talk about the disease prevention or inadequate nutrient intake. So studies mainly focused on the inadequate nutrient intake, and the in-depth analysis of secondary data was done on nutrition indicators including food access, availability, dietary intake, preferences and practices of different populations, household level expenditures, socioeconomic conditions, as well as analysis of dietary affordability and interventions modeling. All these were done using the cost of diet analysis tools. And we have seen like the results were mainly in the form of who are affected, the vulnerable population groups, where they are affected, the urban, the rural, and which regions, when are they affected, the seasonality was identified, and compounding factors, as well as the quality of quantity of intake. So this secondary data analysis yielded the summary of results which are presented, like 60% of the households were unable to afford a nutritious diet. Affordability turned out to be the greatest barrier. Poor quality and quantity of dietary intake was one of the main concerns. Similarly, the feeding practices were also one of the main challenge. And the last one, the strengthening of transfer, was one of the recommendations that came up, that if we need to address these the challenges, we must come up with a mega program that should take care of maternal nutrition and contribute to stunting prevention. Next, Rita, please. So now we all know COVID is a global challenge, and learning about it. And I would say in Pakistan, the preparations started as earlier as January or February. And we are lucky enough, or a blessing in disguise, because the country has been through a series of emergencies, starting with the earthquake, later on the emergency floods, then the internal conflict. So the clusters were prepared, and they converted into nutrition working group with multi-sectoral contribution, and they come up with the anticipated impact of COVID-19. So COVID-19, we were mainly anticipating, if I talk about the nutrition working group comprising of government, all UN agencies, the main worry was about the prolonged anticipated social distancing and lockdown. So it would obviously have impact on food security systems, losses of lives, and barriers to market access, businesses, and again, putting a lot of burden on the already meager resources at household levels in the communities. So there were plans were also devised on how to reallocate resources, how to divert more resources into which areas which are needed. Past experience was considered, not in viral context, but it's a unique emergency. So it was all new for everyone. But I believe that if I look at the preparation at country office level with all stakeholders, including government, we came up with a set of preventive measures which are coming on the next slide. Next, please. After this slide. So this slide just captures the 1,000-day initiatives. I will not go into in-depth. All my partners online, they are very much familiar with the importance of 1,000 days intervention. And it's mainly if you look at almost 75% of these 1,000 days comprise of like contribution from maternal side. If we look at maybe behavior change communication, whether when the pregnancy starts and the antenatal care, then the dietary patterns, EPI's role, then similarly the postnatal care, and then the birth of the newborn, and how to proceed further with the integration of nutrition under the primary health care services for children who are less than 2 years of age. So all these interventions, I will not go into detail because all my partners know the importance of 1,000 days. I'll proceed with the next very interesting slide. This summarizes how Pakistan, the UN community, the host government, and all cooperating partners contributed to proper planning. Next, please, Rita. So if we look at on these columns, like it summarizes how national and provincial nutrition working groups were activated and how they closely worked on minimizing the impact of COVID-19. One of the key example is in the second column, like the nutrition working groups, the government, they came up very quickly with simplified, revised COVID-19 SOPs. And these SOPs were floated and shared with all partners for feedback, different sectors, not just nutrition or health sector, but also other nutrition sensitive collaborating partners. And recently, these were also converted into the local languages for all different provinces. So work is still going on. It will be a living document because COVID is new to us. So we will continue to refine it further. Similarly, there is a big role for IEC material to be developed, including mass media campaigns, role of electronic media, as well as the role of existing partners on ground. So there is a lot of effort, WFP on its own, as well in joint collaboration with our partners. I'll quote example prominently of UNICEF, like they have initiated work on IYCF. WFP has initiated work mainly on the 1,000 days concept on how to sensitize social distancing, as well as promoting the complementary feeding. Similarly, the role of integrated UNICEF and WFP piloting context. I'll quote example, I'm personally in Peshawar right now. So in Khyber Pakhtunkhwa and for tribal districts, we have considered innovative approaches like focusing jointly on areas in federal, in the bordering areas which are more deserving. So this will help us reduce the cost. It will improve our convergence. It will also help us integrate the services under one roof, and the simplified COVID guidelines can be better applied. Last point is about innovations like non-traditional partners in nutrition, especially. I'm not saying about other countries, but in Pakistan, we are in process of collaboration with other partners like UNFPA, how to utilize this joint platform of reproductive health and nutrition for maximizing the access to maternal nutrition as well as other services for reproductive health. Rita, may I request for next slide, please? Okay, so again, I have briefly touched on this, but these are the key examples of how strategically we are proceeding with the different sets of initiatives in Pakistan. The first one, if you look at multi-pronged approach of preventive and curative interventions jointly with the government through their primary healthcare systems. So there are various examples available at different provinces where we have multi-pronged approaches involving multi-sectoral. Some of them are even funded by the, partially funded by the government. So greater prospects of sustainability are there, and contributions are coming from government as well. The second part relates to CMAM scale-up, and I believe it's one of the most important, because if you look at pregnant and lactating women directly contributing to maternal nutrition, they constitute more than 50% of the caseload. And the third one is a more sustainable option, but again, the Benazir Income Support Program, one of the most long-running and most funded project of government, where social protection is provided through, and with some innovations are coming up in the form of conditional cash transfers, as well as nutrition, specialized nutritious food product for the prevention of stunting. Next, Rita. Next, please.
Great. Thank you very much, Dr.
Sorry, I just got a bit of interruption. Thank you so much. That's all from my end, and thank you to everyone for listening to me. Thank you.
Thank you much. Thank you very much. We'll very quickly, we have Vani back online, and we'll very quickly go back to her presentation on India. And
thank you.
Thank
yes.
you.
If you can go to the first slide, and apologies for this IT issue. All right, colleagues. As I said in my previous discussion with you, that I'll be sharing with you how the different development partners have been working to support national and state governments in implementing a health sector-led systems approach. I did talk about why health sector, because health sector is leading the COVID response, and why systems approach, because nutrition interventions are embedded in the antenatal care program of the India, which is delivered through a systems approach. Now, most of the nutrition interventions of the antenatal program are aligned to the global recommendations, and these are delivered through 2.4 million health and nutrition frontline workers, a nurse for every 5,000 population, and one health and one nutrition worker for every 1,000 population. Where can women get these services from? Women get these services through antenatal checkups, which could be a walk-in through facility, but for outreach, antenatal village health and nutrition days. And in addition to that, there is one additional day for high-risk pregnancies, wherein women can also avail an additional antenatal checkup. So in total, at least 5 antenatal checkups are being provided. Nutrition counseling, women can get through group meetings and home visits. The services are delivered through 2 flagship programs of Ministry of Health and Women and Child, and the presence of an overarching nutrition mission provides an additional impetus to maternal nutrition, because 2 of its 5 targets are related to maternal nutrition. So the bottom line is that maternal nutrition does receive focus in India's antenatal care program, and there are systems in place to deliver it through a systems approach. The WHO health systems approach is adapted, including 2 more pillars, equity and community engagement and communication. Next slide, please. Next slide, please. Next slide, please. Next slide, please. So what did COVID really do? Previous slide. Previous slide, please. So what COVID, yes, what did COVID do? All the gains that were made in improving the coverage of maternal nutrition over the past 3 years, COVID disrupted that. As you can see, this is administrative data from the government health management information systems about receipt of antenatal services month after month. And whether it is ANC registration or whether it is IFA, calcium or deworming, all the coverage for each of these dropped to less than 50% in the month of March and April, where more than 90% of the states got affected by COVID. But what did COVID really do was that it also disrupted the information systems for reporting, where these interventions are reported. And it unmasked the system's capacity to support delivery for the most marginalized. So what is done? Next slide, please. To have a comprehensive response, you need a solid storyline. You need an indicator. So as development partners supporting national governments and state governments across the states, the focus right now is to support and strengthen the system's capacity to continue maternal nutrition diets, services at the time of COVID-19. And we hope to mark our success indicator as maternal nutrition coverage, and like in the previous slide that you saw, reaches its pre-COVID level. And obviously, different states are at different coverage level, even pre-COVID. So their targets are different based on their typology, and the state's resilience and their capacity to respond to the pandemic and get these coverage levels high will also be determined by their situation at pre-COVID level. Next slide, please. Giving you a few highlights of the systems approach and how it's being implemented. The systems approach was already in place. What we've done is to apply a COVID lens to the systems approach. Let's look at governance and leadership. Right from the time when the COVID response by the ministry started, the direction that was given was, irrespective of lockdowns, maternal nutrition will remain an essential service and should be continued. In terms of service delivery, while it was center-based first, today it is not center-based, it is community-based with physical distancing, and it has restarted in facilities, and it is now also moving doorstep. India has a good take-home ration program, and also in some states, wet feeding programs were happening. However, those programs are now not center-based, but now the delivery is moving to doorstep, and the types of commodities are changing to dry or to take-home ration with or without egg. In terms of human resources and capacity, the trainings have moved from face-to-face, online, telecalling is being used, retired health staff and NGOs are being roped in, and India has huge academic partners who are being roped in for technical advice and support. Information systems are largely COVID driven. So nutrition indicators are we're trying to integrate those nutrition indicators in the information systems of the government that are being used for COVID, whether it is rapid assessments, whether it is the district reviews that are taking place, and also development partners are now coming together to also have nutrition information systems to let us know about food security and nutrition services that are of their uptake and the problems that are being faced by end providers. In terms of financing, 0.3 million USDs is being given to every district administration for COVID response, which includes nutrition. However, the ring fencing budget for nutrition response within COVID needs to be studied. Partners are co-financing, and allied ministries have also come forward for support. In terms of equity and demand generation, which are two additional pillars, in addition to the WHO health systems approach, SHGs are being engaged, specific strategies are being implemented for the women who are at nutrition risk, specifically anemic, and NGOs are being engaged. 60 seconds of WhatsApp videos are being used, phones are being used, tele messages are being used because you cannot have face-to-face, and strategies are being changed based on the high-tech areas, medium-tech areas, and the low-tech areas. Low-tech areas is where the problem largely lies. Virtual trainings and video repositories are being used. Next slide, please. So despite all these efforts, it's just a beginning, and there are huge challenges that we are seeing in the field. And I would like to walk you through some of these based on the voices that have come from the frontline cadres as well as program staff. The frontline cadres have clearly mentioned about job loss, livelihood lost, rising food prices, stigmas in the community, fear in the community to even take those outreach services, and access to fruits and vegetables is reduced. The frequency of service delivery has actually reduced. The distance to avail services has increased, and distance to provide the services by the service providers has increased. From a program manager's perspective, managing reverse migration, managing low outreach turnout, despite putting all the efforts, information overload, and ensuring the delivery in urban slums still remains a challenge. Also, the response is COVID specific to continue ensuring that maternal nutrition receives its focus in the overall COVID response is also challenging from a program staff perspective. Finally, to summarize, I would like to leave you with 5 messages. Next slide, please. Pregnancy has its risks. We also know about it. And COVID has undeniably added additional challenges in the receipt of services, maintaining healthy diets, and overall home support for women. But it has also given us an opportunity to move into maternal depression and maternal psychosocial support, which have now come as new ideas to integrate into the maternal nutrition program because of the fear, anxiety, depression, and violence that is also now evident in the field. COVID-19 has undeniably unmasked the system's capacity to reach to the poorest with equitable access to both public goods and services. We feel that systems approach and putting a COVID lens to it is serving as a good program tool because it is helping advocate, it is helping support, it is helping monitor a comprehensive response, but most importantly, it is helping tap the existing partnerships and nurture them, each partner picking up the pillars where they are have strengths to support the government and coming up with a holistic response where everyone contributes. And you can see that today's presentation itself has 11 partners coming together who all are contributing to this response. We feel that equity with dignity is an important pillar in this whole systems approach, and how you actually deliver services in the poorest areas with dignity will be different from others and will require more resources. And finally, how the learning agenda around the systems approach will be weaved is also important, because a story without data is only an opinion. So data is needed to back a story. A learning agenda is needed that whether the systems approach really worked to actually respond to the poorest, who need it most, both immediate in the mitigation phase and long term. Thank you very much.
Thank you very much, Vani. Thank you very much to all our presenters. We'll go to our question and answer section now. Very quickly, I just want to highlight, we had 201 of you vote for our poll. Many of you are currently planning, are currently running programs or planning them. If anyone on the call today, on the webinar today, would like any support, you can go to the GTAM website for either in-country support, to hire a consultancy, or to get technical advice. There's a number of ways for you to access that support. Now we'll have Colleen with our question and answers at this time.
Hi, everyone. Thank you very much for the active chat box and questions that we had going throughout this time. Now, I'm going to focus on asking questions that came in related to the case studies that were shared. And if we have time, we will try to go back to some of the general or broader questions. But be assured that all of your questions have been recorded and documented and are being saved. And there are various platforms which we are putting questions out related to COVID. You can go to the ENNet platform. They have a COVID channel. You can also go to the GTAM website, and there'll be some questions and answers there. So if we don't get to yours today, don't worry, it's not going to be lost. Maybe we can start by going back to our first presentation from Somalia. Now, the Somalia team, there was a lot of interest in the e-veggie program. So some questions are, could you just explain what that is? And a follow-up to that is, how do you ensure that the amount of, or that the funding that's given to women, how do you ensure that it's used to provide or to purchase what it's intended, fruits and vegetables, as opposed to other things. So over to the Somalia team, if you would like to answer that one to start us off, please.
Thank you so much for the question. E-vegetables, and it is a kind of cash-based transfer which is provided to the mothers linked with the social behavioral change communication and maternal and child health services at the health facilities. So it is a conditional transfer, and mothers are given an e-voucher based on the attendance in the health services and attendance on the social behavior change communication, which is basically the health and nutrition education sessions in the health centers. So once you have the e-voucher, then it's a voucher-based program, and there are 16 commodities which the mother can procure from the local retailers. When we say fruits and voucher, actually this is more on the diet diversity. Therefore, the mothers can also buy other commodities such as egg, milk, and also some cereals. It depends what she wants to buy within the commodities given in the voucher. In terms of, there's also question I saw in terms of 68% of WDD, MDDW, 68%, and if there is a baseline survey around it. We don't have baseline survey, but we did also a comparison group, and in the results showed that in the non-beneficiaries, it was lower at 21%.
Mm. Thanks for that.
Yeah.
Oh, sorry, I didn't mean to cut you off. Go ahead.
No, I think I covered it up.
Okay, thank you. Some other questions came in regarding the experience in using family-led MUAC, and just in terms of the training of that. How is that done in the context of COVID? Did you use any media or audiovisual aids? So maybe the Somalia team, you can speak to that as well. Can someone from the Somalia team speak to your experience in rolling out Family MUAC and how you did it, and if you used technology, how that was part of it?
Yeah, thank you. Kiara was supposed to talk, but then she's kicked out of the meeting.
Oh, sorry.
So in terms of what we did in Somalia, once this COVID situation hit, we first had a virtual training of all the nutrition partners in Somalia. Then based on that training, the different zones, we have 3 zones, Puntland, Somaliland, and South Central. Then we had, the zones had training of the frontline workers. So those were done through WhatsApp group call. After that, then of course they had small groups of the CHW, the community health workers, not more than 10, with clear following the social distance, the infection prevention control measures. And they were shown how to do that, the training in a small groups. And once they have gone down to the community, the suggestion was to demonstrate, for example, on their child, because the community health worker come from that village. So they will demonstrate on their child. Then each mothers, right now we are in the process of distributing all the household to have MUAC tests so that they can monitor the nutritional status of their children. But the CHW would then demonstrate to the mothers in her village, surely keeping the social distance. So that has been cascaded all the way down to the household level. Over.
Thanks very much for that. I'm going to move. Oh, sorry, go ahead.
Kira's back in, sorry. Yeah, and I just saw that there was a question about the sensitivity about when we do that and ask families to do it themselves, and how do we control for that. And yes, really we're expecting that then if a family thinks that their child is malnourished, that if the band is yellow or red, that they would take them to the health facility. and then it's verified at the health facility by one of the health facility workers. So even if a family measures it wrong and their child is not actually malnourished, that will just be checked when they get to the health facility. And then the tools that Jacinta mentioned that we shared, I could share my screen if people would like to see them, but maybe you want to move on to the next question. But also that cascade training is happening now as well. So partners across the country are rolling out the online training that we did, because all of the trainings were recorded and put on the Nutrition Cluster website. So partners could download all of the trainings that we did on Zoom like we're having now, and they could download them, or they could view them, or they can share them however they want. So that helped to make sure that the training that was done made its way down. And then WhatsApp groups had been formed at different zonal levels. And so that was being actually led by different zonal government partners to have more cascade trainings again, to get the information down to the community health workers. Over.
Thanks very much, Kira. We won't take time to share your screen now, just because there are some other questions that I'd like to get to. But if those tools are available publicly, then maybe we can follow up with you after and just make sure that a link to that is included along with the materials that are shared on this webinar. So, okay, I want to move to Pakistan now. So in the Pakistan presentation, it was talked about how cash support is provided. And so there were a few questions that came in to how is that being delivered in the context of COVID. And a second part to that is where you have the context where access to food is low, and that services are not being utilized to the same level they were before. How is that cash actually working in that context? So maybe our colleague from Pakistan can just speak a little bit more to your experience in the cash program.
Yeah, thank you so much, Colin. And I'll start with the cash one first. If we look at the program is actually part of one of the biggest safety net programs in Pakistan. The program was initially introduced for reaching out to poorest of the poor in the country. And it has been active for the last almost like 9 or 10 years almost now, and has survived different political governments. So the name is still affiliated to Benazir Income Support Program, the late Prime Minister of Pakistan. However, it has continued through 4 or 5 governments because the large number of beneficiaries are depending on it. So what happened, how it got linked to nutrition is the important, interesting part, because after when I mentioned the study, the FNG in 2016 and 17, the findings were interesting, and it convinced the government to consider nutrition support under these projects. So 2 approaches were introduced. One is in the form of specialized nutritious food, the ready-to-use supplementary foods, which are locally produced for pregnant and lactating women, as well as children less than 2 years of age, and cash component. The cash component is mainly handled through, I would say, kind of subcontracting in different districts. So a bank, for example, is hired, a bank A, for example, and it has subcontracted it's more like a mobile cash transfer. So code numbers are sent, and then they can receive the cash from different outlets throughout the country. You are right, in COVID context, how they would receive the cash, what will be the implication? Yes, some of the safety measures were introduced. For example, I'll quote one from the existing WFP projects, how we manage cash in COVID context. So for the number of beneficiaries, the days were divided. If you were to complete a cycle in 7 days, the cycle will take around 21 days. And the number of beneficiaries are segregated for different times. So this is one of the role of cash. This is how it got introduced. So FNB, the Fill the Nutrient Gap, was the main initiative which convinced government in terms of data to consider and invest a lot of cash into nutrition. So nutrition is actually not only taken through cash, but as well as the ready-to-use supplementary foods. Access in Pakistan, it differs region to region. So, for example, in Balochistan and Sindh, you have scattered population. In Khyber Pakhtunkhwa, or the newly merged district used to be called erstwhile Fata, there we have difficult to access terrain. The terrain is posing the accessibility issues. But again, the good thing about the context in Pakistan is the widespread availability of financial service providers, mainly handling cash through mobile phone systems and these. WFP is also in process of introducing innovative technologies, like we call it SCOPE. SCOPE is kind of a electronic registration tool for beneficiaries, which can be used for different wallets, not just cash. It could be used for different wallets. It can be used for vouchers. It can be used for food rations and other things to different service providers. Thank you.
Another question for you there in Pakistan, related to the government's education and counseling work around primary health care. Obviously, that's been affected by COVID, the context of COVID. So can you speak to how the programs are addressing the counseling, the education piece in this current COVID time?
Yeah, thank you so much, Warren. And one of, I would say, interesting question, something which was initially very difficult in the initial phase of COVID. Very, very challenging, and because most of the software component in terms of counseling or behavior change communication relied on the lady health workers program in the country, which is one of the backbone of the primary healthcare system in Pakistan. Whether you talk about healthcare system, whether you talk about nutrition activities or other reproductive health services, they are all relying on the lady health workers. The essence is that the lady health workers belong to the same communities, the same community. Some modifications have been made, like previously they used to gather at health facilities. Those adjustments are made. The role of PPE has emerged. So initial 1-2 months were very challenging. Now government is doing its best to provide PPEs. The essence of UN partnership is also there. For example, WFP under all its project is providing PPEs, protection, personal protection equipments, not only to its own project staff, but also to the government healthcare facility staff. And last thing is that whatever activities are delivered from the UN, these are actually through the primary healthcare system. So no parallel systems are established. So whatever we are contributing in terms of protection against COVID is strengthening the government as well. Thank you.
Thanks. Thanks very much for that. So on to India. So in the India presentation, it was mentioned that there are some new components of programming related to mental health that are being added now. So the question is, can you tell us a little bit more about those components? What are you doing to address mental health issues within your programs now?
Thank you for your question. Now, when we look at overall maternal health package, or we look at maternal nutrition package, or we look at maternal mental health package, earlier each of these were considered separate. So in India, you have a separate ministry looking at the mental health program. They have their own cadres, they have their own systems, and right now through helpline numbers, they are providing psychosocial support to families, communities, and pregnant women. They're also conducting training programs. Now, when the COVID situation happened, pre-COVID, maternal psychosocial support and nutrition were not correlated and putting together in one package. But the situation in the field triggered us to bring 3 partners together on one platform. That was the National Institute of Mental Health Sciences, which is a training institute for mental health in the country. Maternal Health Division, which is providing the overall antenatal services, and the nutrition component within it. So right now, the Woolley scale is used by the mental health units to assess anxiety and depression amongst women, and link them up to community mental health counselors and their own cadre. However, this is a very new area, colleagues. And had it not been COVID and the violence that was reported in a number of families because of the stress, fear, anxiety, and loss of livelihoods, probably if we had not used the systems approach, we would have not advocated for this to be put together. So in terms of the field for harmonizing psychosocial support as a part of maternal nutrition package, the beginning has begun where the algorithm now is merged, but so the buy-in, the leadership buy-in and the trainings are now going to be together. How it rolls out in the field is we will be able to see in the coming days. Because we have to understand in India, it goes through a systems approach. But COVID provided that opportunity to bring the three departments together rather than doing it separately. Co-financing is bringing the players together. There is some work that is happening, in randomized control trials with community health mental workers. However, merging it with nutrition programs, we have seen little work at scale for the 30 million pregnancies.
Thanks very much. A related question was asked around the cadre of workers that we are often relying on to deliver services for women are the same workers that have a heavy load right now in providing infection prevention and control activities and work. So in India, how are you managing the workload of those frontline cadres? Given the context of the COVID demands plus their other services and jobs they need to do?
So thanks for that question. In India, as I mentioned, that there is one nurse for every 5,000 population, and there is one health worker who's community-based called Asha. However, there's also one nutrition worker, the Anganwadi worker, with her helper for every 1,000 population. And in India, while the response is using the health systems approach, however, it brings together two different ministries working together. And so there are workers in the field for the nutrition response. But it's true that frontline cadres are engaged in huge active surveillance. So there is another untapped group I will not say untapped, but there is another allied ministry that supports these frontline workers. And you would have seen that in my Equity with Dignity pillar. And that is the women's self-help groups. And the women's self-help groups, there are a group of like a thrift and threaded group or a savings group. And in several states, the women's self-help group cadres are supporting the frontline workers in PPE, in nutri-based livelihoods, in community support systems, and also providing doorstep delivery of commodities and food in support of the COVID response. So there's a huge cadre of women's self-help groups in most of the states. It is relatively good in some states as compared to others, but the beauty is that it's a part of the National Rural Livelihood Mission. And there was another question which I saw, that how are you bringing allied ministries together on nutrition sensitive components? So basically they are taking on the job of food, nutrition, health and water wash promotion, as well as nutri-based livelihoods in their programs. So women's self-help groups is a boon and a silver lining to support the frontline workers. And it's a huge number in India.
Thanks very much. There has been a couple questions come in about models and approaches to have male involvement in this area. So maybe Nita, if I can ask this one to you, what experience or is there models can you speak to that engage men in this area as it relates to maternal health and nutrition?
Thank you for the important question. I mean, as we know from even in non-COVID settings that there are many barriers, social norms for women to have nutritious diets and have access to services, and that male members of the household, husbands, fathers, and all can play a very important role in ensuring some of these barriers are lifted. So this is an important part of the overall communications approach in the context of COVID-19, is to make sure that using some of these existing research and analysis, these are in place, is to make sure that we use them to provide the conditions so that male members of the household can be involved. There are some interesting models in the literature that show that essentially that in those households where male members are more involved in ensuring access to services, in ensuring that women are able to access nutritious diets, that these do result in positive outcomes in pregnancy. I was just wondering maybe if the countries had some specific examples to show that might be useful here.
Yeah, that's great. Anyone on our case study panelists would like to share on your experience in male involvement?
We've just begun some of that work in India with the state rural livelihood missions because they were working on women-to-women approaches to address gender norms for improving diets in pregnancy. However, we're trying to see how men can get engaged, but that's early works. Looking at engaging men for improving nutrition outcomes in pregnancy before COVID was also not there. So we have seen that whatever was available pre-COVID could be adapted during COVID, but new things could not, we're not in a position right now to start new things. But this is a part of an impact evaluation that we are engaged in on gender and nutrition, and to get to seek a participation of men for nutrition outcomes. And while in the first 2 months of the COVID response, these programs had to be halted, but we will hope to resume them in another 15-20 days. But very little research is there on this gender pillar of engaging men in nutrition response.
Thanks very much. I'm just going to finish us off here with a really practical question for our World Food Programme colleagues. We were asked here by a colleague just about how to maintain the physical distancing when you have a distribution going on. Their experience has been, even if you ask people not to come all at once, they do, and they crowd the area. So I'm just wondering if you could speak a little bit too about what WFP guidance has put in place around maintaining physical distancing. So I'm not sure who would like to handle that off the panel, but if one of our WFP colleagues could, that would be great.
With the permission of Deborah, I can respond here.
Yes, that's fine.
Because I would wish to quote very recent examples post-COVID. So first one is not directly nutrition, it's a general food distribution. So what we did, we engaged WHO. We did the online training for the staff of NGO which was involved in COVID. PPEs were provided, and then the GFD was proceeded, and it took, like I said, additional 2 weeks were taken, and provided the 6-meter distancing limits were applied. This was GFD. Then if we talk about nutrition, the revised simplified guidelines already identifies a situation for partial lockdown, situation for full lockdown. Both are addressed. So flow charts are provided for staff members. Some of the projects have kick-started, some are about to start. In the scenario of full lockdown, where the COVID viral situation remains and the social distancing is essential, we are opting for doorstep delivery. The coordination is done through the local lady health workers, and then WFP mobile activity teams are delivering the food but after every 2 months, not on the periodic fortnightly or monthly basis. We have increased the duration. So we provide them a 2 months ration. So this is the approach. Similarly, I'll quote also a few things on MOAC. We have increased the number of MOACs. 2 options are at hand. We will continue as much as resources allow to go for disposable MOACs. Second option is the isopropyl alcohol patches, which we provide in small sachets, and those will be provided to the healthcare workers. So these are the practical steps. Thank you.
Thank you very much, Dr. Habib. So I'm going to close this Q&A session now, and thank you very much for all of your great questions, and passing back over to Brooke.
Great, thank you very much, Colleen, and our other colleagues. So we'll go ahead and start wrapping up the webinar now. We have a number of webinars available on the TechRRT website on COVID and nutrition that you can see here. The webinars are all in English, French, Spanish, and the IYCF webinar is in Arabic as well. There's various partners who are involved and supported along with the TechRRT and the GTAM. Next slide, please. There are programmatic adaptation teams that are working across IYCF, micronutrients, wasting, and NIS that are working to collate all the questions that you have, not only from webinars like this, but from ENN forums, from the GNC help desks, and so on, working to create live Google documents to keep up to date with the information that that's being requested or needed in the field from the people giving the programs. So you can go to this this link here to access those documents. Next slide, please. And I just ask that please fill out the SurveyMonkey, our SurveyMonkey evaluation for this webinar. We can ensure that we're getting the right information to you in the best ways possible with your feedback. And if you want any more information or to look at any of the other TechRRT webinars, you can go to the TechRRT website. And we just want to thank all of the presenters today and all of you for coming and participating with your active questions, the active chat box, and for being a part of this webinar. And not only for that, but for all the work that you're doing in the field. So good morning, good evening, good afternoon, wherever you are in the world, and thank you very much.
Many thanks, everyone.
Thank you so much. Take care.
Thank you. Bye.